So I'm curious about what actually happens. I mean, besides of it being more instant than SSRI, what actually happens to a person that has, I mean, I have PTSD, so I know what it's like, but what happens to you when you go on the treatment? What actually happens in the brain or in the person?
In the brain and the person may not be, one may be a little different from the other, though of course they're related. But the person is more than the brain. Yeah. And the brain and the mind, the brain is a portion of the mind, if you will, in my estimation. On a biochemical or neurochemical level, what's happening is the ketamine is stimulating brain-derived neurotropic factor via AMPA or GABA or both. And the result is brain-derived neurotropic factor becomes increased in concentration, and it leads to the actual establishment of new neural connections, particularly in the hippocampus, the amygdala, the prefrontal cortex, and greater receptor density. If you picture receptors as keyholes, for every square centimeter, there are 10 keyholes, and after you give this, there are 16.
That sounds like a psychedelic. It sounds like it acts like a psychedelic as well.
Well, I'm not sure what a psychedelic is, but it definitely is mind-altering. Yeah. And psychedelics, if you divide them into the botanicals, like mescaline or psilocybin or ayahuasca or ibogaine, and the chemicals, the synthesized agents like LSD, like phencyclidine derivatives such as PCP. These agents also are psychedelic, MDMA. Yeah. These are very recent discoveries. The botanicals have 5,000 years or 6 of experience, but no real data. And we don't know when we take a botanical really what we're taking. And we don't know if we synthesize what we think is the dominant ingredient, how that's like the botanical and how it's not like the botanical.
Ketamine's more of a dissociative anesthetic than a psychedelic, in my opinion. And I think a lot of people would make the distinction, and with what Dr. Mandel is saying, even for the botanicals that have been around for as long as they have, we have really very little data on them. Whereas ketamine, hundreds of millions of administrations over 50 years, there's a tremendous amount of safety data. Now, obviously, fewer administrations for mood disorders or chronic pain conditions than as an anesthetic, but still a substantial amount of research on it for those more recent indications. And the newer medicines like MDMA, or at least newer as far as being viewed as potential solutions to these afflictions, MDMA-assisted psychotherapy, psilocybin, the active ingredient in magic mushrooms. These medicines have a tremendous potential to heal. We're only just now starting to even be permitted, at least in this country, to be able to do some really important research on better understanding the safety and efficacy of them. So ketamine really is in its own class in that way. It's also used in veterinary medicine, I wanted to add, because many people's connotation with it is a horse tranquilizer or a cat tranquilizer, and that's a very common response when you mention ketamine, and they say, "What, you're giving that to humans?" Yeah. Or people say, is it even legal for you to give that to people? And I always have to kind of laugh, and the education gap is pretty big, even among the medical community. I recently had someone say to me, I work in medicine, I know many esteemed doctors. I've never heard of this, and it can't be real.
I've never heard of it, so it can't be real.
Yeah, and you're taking advantage of people. And I said, well, I would invite you to learn a little more. I didn't know that you and your colleagues learned of all innovations the moment that they were popularized. It's terrible, but we try to present the facts and help people to learn more when they're willing.
You make some really important points, Sam. For a variety of reasons that are fascinating, that could merit an entire show or book, the United States government in the early 70s decided to interdict all of these medicines, chemicals, substances. Ketamine escaped by the skin of its teeth because it was the most widely used anesthetic in the world. The others were all interdicted. They were scheduled to be absolutely verboten, not only for human, ordinary civilians, but for people who wanted to research them. It was just not possible for any of these agents to be researched. The only reason ketamine survived because it's wide use and as an anesthetic. It was so safe, so effective, and we get literally hundreds of millions, probably billions of administrations over 50 years. We have a good database. One of the tragedies of banning a substance is, of course, exploration of the substance still goes on, but all information is lost, and what isn't lost is suspect because of the manner in which the information is collected and stored. It's a tragic outcome to ban something that could potentially be useful. There are many more constructive ways to modulate its use and to regulate its use.
I would really like to know how the connection between the ketamine treatment, creating more neurons, and the expansion of the amount of these keyholes that you talk about, how that helps someone with PTSD or an anxiety disorder or depression. What actually happens?
Okay, you asked and I started to answer on a molecular level. So you have more connections and you have more receptors. On a more macro level, you're able to go to material that either was very elusive to bring up at all, or that when you were able to bring it up, it came with it a huge amount of affect, which was very off-putting.
Yeah.
If I could make one analogy or point one thing out that may not be clear that I think could be helpful in putting the more kind of technical explanation together, is that a depressed brain or a brain with PTSD, you can actually see parts of the brain that are not functioning well, like physical, measurable on a scan, that these parts of the brain that are involuted and actually not operating at a healthy level. And the processes that Dr. Mandel is describing, that ketamine starts and is supportive of when it's given intravenously for an infusion at a sub-anesthetic dose, like we're doing for ketamine therapy, it actually can start to plump up and heal these parts of the brain, increase better connectivity, better function. So it's not just an experience, and there's definitely the psychological aspect, which we definitely will talk about, but it's actually causing healing and on a measurable level. And that's some of what the process is that Dr. Mandel is describing. Just wanted to point that out.
Thank you. You can make use of that enhanced brain function to look at what we say is the elephant in the room. For someone with trauma, perhaps they are continually being triggered by a experience that they only dimly remember. And they only dimly remember it because any attempt to remember it with more clarity is so off-putting, is so triggering, is so alarming. The ketamine perhaps is an anesthetic for that affect. So you can experience what has been going on in terms of what actually occurred without the affect and without all the stories that have grown up in your mind around it.
Right, because the trauma is caused by an experience which was too hard or painful for the person to handle, and then it's almost like closing that trauma into a room and locking the door.
Yes.
And the ketamine is the key to open that door.
Yes.
Some people do that so lock it so deeply they literally don't recollect it.
Yeah.
And we've had patients who have actually come to realize trauma during or after an infusion that they had buried for years and years and years. That was literally the source of so much suffering, whether it be different people, manifested in different ways with different people through substance abuse, people self-medicating, or just feeling, all the symptoms of depression, PTSD, and not really even understanding why. I must be broken. It must be a chemical imbalance. All the reasons from different providers or people that they could get for why they might be this way. And it turns out they have good reason. And most of us, almost every time, there is a good reason why, and there's something that can be worked out to heal from the pain that we're suffering from. And this particular patient that I'm thinking of was molested when he was younger by someone close to him. I believe it was, I don't know if it was a neighbor, an uncle. This was about 4 years ago. I don't remember the details exactly, but it was life-changing for him to come to this realization and to then be able to go to therapy to work through it and to overcome it. He was very grateful, of course. I'm sure it wasn't a pleasant thing to come to realize, but he was grateful for it.
So I did basically a version of that with trauma exposure therapy. So that was, I mean, the principle is the same. You get help to walk into that room, but I had a therapist with me holding my hand, helping me to feel safe enough to open that door and visiting the story and almost like with her support deflating the significance of the story. A
physician, a psychologist, is Naim a psychiatrist? Psychologist, excuse me. Dr. Naim is a psychiatrist friend of ours, and he talks about an analogy that when a plant is not getting water and the leaves are browning, that you don't say it has brown leaf disease. You say this plant here needs water. And that this is a beautiful analogy for modern medicine, is running around and telling people you have brown leaf disease and, you have, sour root disease and all this and that. And at the end of the day, most of us just need a little water, maybe some sunlight.
Yeah.
And
for sure.
I think, ketamine really does help to get at the source of these afflictions. And it's not the end-all, be-all. It's not a cure, as Dr. Mandel said. But it is a wonderful beginning to getting the energy and the relief needed to start to really look at these things and get involved in talk therapy and in healthy lifestyle changes that can help you to maintain a better life.
So how would you describe the treatment itself? What does it look like? What kind of people?
People from all walks of life.
Yeah.
All ages. All gender identifications. Most of them are functional. Some of them are really quite impaired in their ability to function. We have people who spend most of their time in bed, literally. Because they're afraid or because they just can't get organized enough. It's just such an effort to do the simple personal hygiene that's necessary in getting out of the house. They come in. We take a history. We do a history. We do a physical. We review previous physicians' findings. We talk with previous caregivers. We formulate a treatment plan, which usually is 6 infusions over 2 weeks, an infusion every other day, for 2 weeks. I should go back to our results are better than the typical clinic and the typical research study because we give a 55-minute infusion and we give slightly higher doses. After Berman's paper, the next big milestone was a guy named Carlos Zarate at the National Institute of Mental Health in 2006 had 28 patients who were resistant to all kinds of interventions, including all traditional medicines. And he gave them ketamine infusions, and 68% of those patients had relief of their depression. And that was really remarkable. It only lasted a few days, and the naysayers said, what's the point of giving that medicine and going through all that if it's only going to give them 5 days? Well, for those people, 5 days was precious.
These are people who didn't respond to anything. I mean, treatment resistant, severely treatment resistant. So to get a response at all was pretty substantial. But I think a lot of them also did get about 7 days.
Yeah.
Some on the higher end, 10. But
some unsung heroes said, well, let's try giving a series. Mm-hmm. And they gave 6 infusions over 2 weeks. Monday, Wednesday, Friday, Monday, Wednesday, Friday. And they chose 40 minutes for an infusion. And they chose 0.5 milligram per kilogram of patient to be given over that 40 minutes as the dose.
0.5 milligram of ketamine per kilogram of body weight over 40 minutes, yeah.
They had 71% relief. And it persisted.
For how long?
It was about 2 months.
A number of weeks. I don't think it was quite 2 months in that original study. But
I mean, for someone who's in agony and in trauma and in depression, one day without that is a miracle.
Yes, it depends on...
because it creates hope as well.
Right. It depends so much on your perspective. From the point of view of the patient, it's wonderful. From the point of view of someone who makes a competing drug, something must be wrong with it.
Yeah, I mean, also
there's a lot of that issue.
Yeah, of course.
A
lot of competition.
A lot of what is really critical for a lot of these patients is to change their environment, and this really enables that. So, the lifestyle choices changes, whether it's unhealthy relationships, whether it's the opportunity to try to get a job or to be physically active again, or I mean, even in 1 week, the amount of changes that can start to occur with support that can help to sustain the benefit, even when the quote, ketamine starts to wear off, is really priceless. And that's what they allege for a lot of conventional antidepressant medications, is that in theory, initially, they're going to get you to a better place that you can make the necessary changes, and then you don't need to take them anymore. Yeah. Well, that's kind of silly now. We see people are taking these medications daily for their entire lives, and often many combinations of them. This is not what it was, what we were sold. And I say we, having friends and family who are stuck in this predicament, and, it's just not... it's not ideal.
Is that what you mean when you say that ketamine is a treatment and not a cure?
Yes,
absolutely.
Because even we've had patients go more than 2 years before they needed boosters, but that's not typical. Typically, they need boosters after a couple of months. 3 months.
3 months is average. It's not uncommon for patients to go for 6 months, though. We have a number of patients who will go 6 months. And also over time with, again, the right support, therapy, lifestyle changes, as time goes on, they can increase the distance between boosters. They need booster infusions. We call them boosters for maintenance. It's usually 2 infusions done 1 or 2 days apart. To maintain the result. It's not another full series of 6.
But the same amount of one treatment?
A 55-minute infusion, is one booster, one infusion, And they typically can go longer stretches before they will need to come back for them. So if you complete a series and say you come back 3 months later for 2 boosters, you may be able to go 4 or 5 months before you come back for 2 more boosters, maybe another 6 months, and so on, for people who are thriving.